السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم هنكمل مجموعة حلقاتنا عن الإميونو سبريشن أند كيدني ترانسبلانت. اليوم هيكون كلامنا عن موضوع السيرولوماس أند إفرولوماس بوس إم ماميليان تارجت أوف رابامايسين انهبيتورز إميتورز. توكل على الله. طبعا الرسمة دي قلت لك دايما هتكون أساس الميكانيزم بتاع الإميونو سبريشن with kidney transplant how this immunosuppression work on the active T cells. Our target today will speak about, we spoke around this diagram in details in the previous lectures. Today we'll concentrate only on sirolimus and everolimus and the mechanism of action on mammalian target of rapamycin and the role for inhibition of cell cycles and no more T cell proliferation. طبعا هنا الإيميتورز السيرولوماس أو الإفرولوماس عموما بيتحدوا مع combine with FKBP12 and sirolimus FKBP12 complex will end by inhibition of this mammalian target of rapamycin will arrest or stop cell cycle and proliferation. Here also we can see this sirolimus and everolimus here working on the mammalian target of rapamycin. Once interleukin-2 come from this cascade and will end by stimulation of mammalian target of rapamycin will end by stimulation of cell cycle, but this will be arrested here from sirolimus and everolimus from inhibition of mammalian target of rapamycin to stimulate the cell cycle. زي ما قلنا بالظبط inhibition of mTOR and it will end by arrest or blocking progression from G1 to S phase in the cell cycle. Also another anti-fibrotic properties ولذلك احنا ما بنفضلوش we don't prefer this medication and the perioperative period for wound healing and less nephrotoxic compared with C9. Again, this is the same. Again, this to clarify another diagram, just to clarify the work of sirolimus here, binding with FKBP12, and will end by inhibition of this emitters, and this emitter inhibition will stop or just block the cell progression, proliferation, and activation. Another diagram just show you this emitters. Will end by this mTORS inhibitor like sirolimus or everolimus will bind with FKBP12 complex here, inhibition of mTORs and end by no more interleukin 2 signals coming to stimulate mTORs, and this will end by cell cycle arrest and no more cell proliferation. Sirolimus also same tacrolimus and inversus or whatever once daily. Same like Advagraph or Inversus once daily should not be taken with the cyclosporin 4 hours apart, at least between pause, because increase the drug concentration of area under the curve around 20 to 130% of sirolimus if taken together. And if taken 4 hours apart, only area under curve increase by 80%. Take care because usually some patients who are using sirolimus and say a small dose of cyclosporin together, especially in patients with recurrent skin cancer, Kaposi sarcoma, or any other skin cancers, can also be taken with tacrolimus by small dose. As little to decrease the C9 dose, you just be adding this sirolimus or just take it out. Metabolized also by cytochrome P450, the same inhibitor and increasing metabolism of this medication like tacrolimus and C9 we discussed before. Long half-life estimated around 30 and 62 hours. Monitor every week if you can. Monitor trough level also same tacrolimus. Early trials they mentioned trough level 15 to 25, more recent just 4 to 8. No renal adjustment for sirolimus doses and less nephrotoxic. Better graft function if introduced early. Take care before prescribing sirolimus or rabamune or everolimus. Take care from the GFR. Better don't prescribe if GFR less than 30 or proteinuria more than 0.5 gram per day because it will give you worse outcome and worsening of this and this if you will given below this numbers and above this number. Take care from estimated GFR and proteinuria before prescribing sirolimus. Also, because it's a little bit not strong like other medication in immunity, just increase the risk of rejection and the graft loss. Multiple side effect, mouse ulcer, proteinuria is a common side effect, peripheral edema, delayed wound healing must be held more than 7 days prior to the surgery, prior any surgery, and hyperlipidemia, interstitial lung disease, pneumonitis, and myelosuppression also. But the most important, put in your mind proteinuria, delayed wound healing, just keep this in your mind. Nephrotoxicity, if given with a high dose of CNI, that's stereotoxic, hypokalemia, hypomagnesemia. Take care from this side effect if you are given with CNI, either cyclosporin or tacrolimus. Delayed recovery from ATN also. Impaired wound healing, use after 3 months after any surgery. Leukopenia, thrombocytopenia, hyperlipidemia, pneumonitis, proteinuria, tubular proteinuria, decreased podocyte integrity. This is a cause of worsening proteinuria. And if your patient have more than half a gram a day, better to avoid sirolimus conversion. TMA, especially in combination with C9, malignancy. We are using in malignancy patient, we are transferring our patient from C9 to mTORSi already, because anti-angiogenesis effect, especially in Kaposi sarcoma, better to transfer to this medication. This diagram just to remind you this mechanism of action in mTOR and cell cycle arrest. And thank you so much, and we'll see you إن شاء الله in video قادم بإذن الله. نتكلم عن الأذر in medication used in kidney transplant. والسلام عليكم ورحمة الله وبركاته. ولا تنسوا المصالح والدعاء، ولا تنسوا الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم، وكل عام وأنتم بخير. السلام عليكم.